The term long COVID was introduced in May 2020. Long COVID is characterized by ongoing symptomatic COVID-19 beyond 4 weeks post-infection. There are more than 200 symptoms that have been mentioned. The NIH used the US Centers of Disease Control and Prevention definition of long COVID as sequelae that extend beyond 4 weeks. Now, different terms are used in different countries, as you can see, but there is another term used, post-COVID-19 syndrome. This is defined as ongoing COVID-19 related symptoms from 12 weeks post-infection. Let's get to the neuroscience, pathophysiology. And ME/CFS and long COVID, are they related? Absolutely. Around half of the individuals with long COVID are estimated to meet criteria for ME/CFS. Similarly, post-exertional malaise is present in the majority of individuals with long COVID. Key symptom, PEM, is present in long COVID. Similarly, orthostatic stress is found in individuals with both long COVID and ME/CFS, similar hemodynamic, symptomatic, and cognitive abnormalities in both of them. And that's why we use the same strategy. Importantly, it is not surprising that ME/CFS should stem from SARS-CoV-2 infection, as 27.1% of SARS-CoV infection survivors in one study met the criteria for ME/CFS diagnosis 4 years later after onset. This is some of the patient descriptions. I was diagnosed with this after having COVID. The fatigue is frightening. I have a hard time getting through my workday. My life has changed dramatically. Prior, I had no health issues, worked long hours, studied for graduate degrees full time, walked 5 miles a day. Now I work as an accountant and can't do anything else except rest and sleep. I had EBV a long time ago. So EBV is closely linked to glandular fever and chronic fatigue syndrome. I have done the research for 2 years with no secrets found for recovery. So I had EBV a long time ago. I now have long COVID. Another patient, she suddenly felt a stabbing pain in her chest. It just got worse and worse, to the point I was crying from the pain. She recalled in a recent interview, at 3 a.m. the pain sent her to the emergency department. I had developed a dry cough, maybe a mild fever, I don't remember, she said. My brain just feels like there's a fog. So the key aspect here is there is an overlap. As you can see here in patients with ME/CFS, antibody responses were significantly stronger. If you do have to differentiate them to some extent, you can see that antibody responses were stronger, particularly for EBV, Epstein-Barr virus, indicating an altered immune response that may be responsible for the prolongation symptoms in some individuals. Whilst in long COVID, COVID-19 is associated with elevated levels of virus-specific antibodies in the saliva. So at 3 to 6 months after mild asymptomatic SARS-CoV-2 infection, there was a strong reactivation. These antibodies signified a strong reactivation of latent viruses, EBV, HHV, and HER-K. So it's interesting, you've got reactivation of latent viruses that might be linked to long COVID. But we know infection, inflammation cascade, neuroinflammation cascade is likely to be similar. I'm going to go through some things that may be slightly unique to long COVID, so you can keep that in mind in your investigation and in your treatment. When it comes to the pathogenesis, broadly, it's the ACE2 receptor that we've got to keep in mind, because the binding of the SARS-CoV-2 to the ACE receptor is the way in which the entry happens. But here's the issue. ACE2 receptor is situated in many organs of the body: lungs, brain, endothelium, heart, enterocytes, and that's why you have this multi-system affection. And the key aspect here is that through the binding, there is the involvement of the angiotensin receptors, the renin, the angiotensin-aldosterone system. And this is where the vascular aspects come into play. Because when we think about depression as such, we're not necessarily looking at prominent cerebral perfusion issues. I'm talking about the functional psychiatric kind of depression. Perfusion issues may not be that prominent. Having said that, there is an entity known as vascular depression, which is known to be associated with more treatment resistance, requiring broader spectrum antidepressants, very similar to what we're doing here. In this case, the vascular issues or the perfusion issues tend to be that bit greater. And this is reflected in the psychopharmacological strategies that we need to use. I find in these patients, the synergy of medications that we need in the initial stages tend to be slightly more than what we would find in a functional psychiatric disorder. It tends to be greater. Having said that, when they improve in about 1.5 years, I find that they're able to come down on those medications quite a bit. Very different picture from some of the functional psychiatric disorders. Relapse can still be present in the context of stresses. So what's the pathophysiology of brain involvement? You can see multiple ways in which the SARS-CoV-2 virus affects the brain. Cytokines, direct infiltration, neuroinflammation, autoimmunity, ACE2 downregulation, post-infectious autoimmunity, gut-brain axis, hypoxic injury. We've got to look at all of this, and this is reflected in the investigations. When it comes to what are the neuropsychiatric manifestations, more in the acute illnesses, you can see broadly they can be divided into the encephalopathies, psychiatric disorders. As clinicians, one of the things I find is that when cognitive impairment is quite significant, EEG can be sometimes really helpful in differentiating between whether it's a functional psychiatric disorder in the form of cognitive impairment related to a depressive syndrome versus encephalopathy.